Okay, let's get started. Happy Thursday, everyone. It's December 17th, and this is the AMCHP All-Member National MCH Policy Call Series and COVID-19 Town Hall. We have a full agenda again today. We will start off with our usual housekeeping. As a reminder, if you have any questions, please do type them into the chat and try to select all panelists and attendees so others can see your question as well. If you have any technical difficulties, you can email Jess Cohen, that's jcohen@amchip.org. And when it comes time for questions and you would like to be unmuted, just raise your hand or type into the chat that you would like to be unmuted and we can do that. And then after we go through a legislative update, we'll have our update from MCHB. We will have some state sharing from New Mexico today. We will be joined by our partners at CDC for an update. And then finally, we'll close out with some reflections and perhaps predictions on what the ACA landscape might look like. So on the legislative front, as a reminder, the continuing resolution that originally expired last Friday, December 11th, was extended for one more week and now expires tomorrow. When they expired it last week, they figured they would have a bill by like Monday, Tuesday, and vote on it before the end of this week. Now they're talking about staying for the weekend, preparing another short-term continuing resolution. The latest that I read as of about an hour and a half ago said they actually are done on the omnibus piece of the legislation. So that is the bill that would contain all of the funding levels for the remainder of FY21, but they're still working out some differences on the COVID relief bill. And they had hoped to marry those all together into one big package, which would also probably help get it through. So there's, the possibility they could separate them and just do a separate vote on the omnibus followed by a vote on the COVID relief package, but it's looking more likely they may just punt again for another few days and stay in until, the weekend, till next week if they need to. The other update I want to share with you, I really hope that we would have something by now, but we'll send a legislative alert if and when there's action on this front. The other update I wanted to share was some of the issues that we've talked about in the past. So one is on MCHB, the maternal, infant, and early childhood home visiting, and whether or not there would be either extra relief as part of a COVID package or possibly even extension of the program. It's not set to expire until September 2022, but there had been interest last year that arose before COVID broke out about possibly providing more funding to the program so that it could expand sooner. The other bills that we've talked about recently include the Maternal Health Quality Improvement Act as well as the Helping Moms Act. And both of those bills have unfortunately seemed to have slowed down in their momentum. So again, the Maternal Health Quality Improvement Act was a bill that passed unanimously. Actually, so did the Helping Moms Act out of the House, and actually most of the provisions of this bill had passed out of the Senate Help Committee bipartisanly as part of a larger package, and this would authorize a few programs geared towards improving maternal health. The other bill, Helping Moms Act, is the bill that, as passed out of the House, would give states the option to extend postpartum Medicaid to 12 months. Both of those are seem to be in peril for various reasons, some political, some related to the cost and, desire not to spend as much on Medicaid. So it's been frustrating. We haven't gotten a final word yet on the fate of either, or any three of these programs, and remain in contact with Congress and their staff, especially the committees of jurisdiction on the House and the Senate side. As you may recall, we recently, and we talked about this in the last call, but the letter hadn't gone down yet. We led a group of over 115 national organizations urging congressional leadership to pass these bills. And we got a really broad, nice coalition of national groups that supported this. And when you get the copy of the slides, you'll be able to read the full letter there. So our Advocacy continues, but I'm not sure what the final language is going to bring. And if we don't see success on these this year, they will be top priority for AMCHP in the next Congress. I also just wanted to mention on the transition front, AMCHP did sign a letter that was spearheaded by Families USA, urging the Biden-Harris transition team to prioritize health and healthcare overall as part of their agenda early on when the new administration takes hold. And AMCHP is finalizing a document that will outline our top MCH priorities. Again, these are never an exhaustive list, but some of the areas that we really want to highlight and will share with the transition team about priorities for maternal and child health include the 4 listed here around addressing racism as a public health crisis, prioritizing MCH populations in the context of COVID and other emergencies, what we call chasing zero, driving down maternal and infant deaths, and making systems of care work for children and youth with special healthcare needs and their families. We'll be releasing that soon as well, so stay tuned for that. And now I will turn it over to Dr. Warren to provide updates from MCHB. Thank you.
Thank you, Amy. Good afternoon, everyone. Appreciate the opportunity to be with you all again. If we can go to the next slide, just wanted to remind you, and thank you first to all of you who have submitted comments for our MCHB strategic plan. We've got a request for information out that closes tomorrow night at midnight. So if you haven't responded yet, please do. The link is here and available in your slides. Or you can email the email box that's listed there on the slides, mchstrategy.hrsa@hrsa.gov. Really appreciate a number of you have already shared that with your network, so we can really try to be very inclusive as we gather input on the strategic plan. On the next slide, really excited to tell you all about this. So you heard us talking in the summer about the declines in pediatric immunizations and well child checks as a result of the pandemic. At the Bureau, as we were trying to look at the various ways that we could support that, we were able to identify some additional funds through our SPRANs, our Special Projects of Regional and National Significance funding line, to be able to support a new prize challenge competition. So this is called our P4 Challenge, Promoting Pediatric Primary Prevention. It is a prize competition. Some of you may be familiar with the challenge competitions we've run before. This is a very different way of doing business for us. So as opposed to the typical grant application where we put out a NOFO and we ask you to send us 60 or 80 pages of application and we go through a scoring process, this is actually designed to get the best and brightest ideas from across the country with a very low bar for participation. So 3 to 5 page application, very, very brief. The goal of this is to gather ideas for innovative approaches for how we increase access to and utilization of well child visits and immunizations within primary care settings. So we're encouraging partnerships at the local level, and state and local organizations may want to partner together. At the core, though, of any of those partnerships, there has to be a primary care provider who delivers health services to children. So we really want to enforce this notion of pediatric medical homes. On the next slide. So the way these challenge competitions work, it's a bit like the TV show Shark Tank. So people will send in their ideas, again, very brief applications, 3 to 5 pages. From those, we will select up to 50 winners from phase 1. So this is just for submitting a good idea. We'll select 50 of those. They'll get a prize of $10,000. And then among those 50 winners, we will ask them to implement their plan. They'll have a 6-month or so period of performance to be able to implement that plan and then measure their success. And then they will report back to us. And from those, we will select up to 20 phase 2 winners, and they will receive $25,000 each. So for entities that win both phase 1 and phase 2, they can win up to $35,000. The website is live. You can see there the link on the screen. We'll actually start taking submissions on January 19th, and they'll be due on March the 15th. This is a really great opportunity for state Title V programs to look, particularly those of you who have priorities around medical home or immunizations or well visits. This is a great opportunity to think about engaging some of your local partners in a way that could potentially generate some additional money for them, which is exciting. So folks can look at immunizations or well visits, or they can look at disparities among either of those. And so this is also an opportunity to think about where we've got opportunities to address health equity in the primary care medical home context. So we are really excited about this. This will be the 6th challenge we've done in MCHB. We're currently wrapping up our 4 grand challenges that started a few years ago. One around care coordination for kids with special healthcare needs, one around remote pregnancy monitoring, one around preventing childhood obesity, and another around substance use disorder treatment for pregnant women and new moms. So we always try to find topics that are timely and important to the field and be able to think about how we can support those through prize challenges. So wanted to make you all aware. You hopefully have seen the announcements of this on HRSA's social media, so we ask that you share that broadly with your stakeholder networks. Again, a great opportunity for you to engage with your immunization partners, with your primary care folks within your state. If you've got hotspots that you've identified as wanting to work on around vaccines or well child visits, this is a great opportunity to be able to promote that and come to the table with potential money as a prize. So thank you all for sharing that information. If you've got questions, please feel free to reach out to us. The website is there. I'm going to also put it in the chat box. And so happy to hear from you if you've got questions. And I think that's my last slide.
Thanks. And Dr. Warren, if I recall, I think you have to jump off early today. So I wanted to point out 2 questions that came in through the chat while you were speaking. One is whether the new MCHB strategic plan is going to reflect the priorities for maternal health outlined in HRSA's plan.
So we're gathering input now for the strategic plan. I think one of our challenges is to cover all of the Bureau's activities in a succinct strategic plan. So we're probably going to have 3 to 5 key focus areas. And through those, we've got to really cover the broad work of the Bureau. That being said, clearly maternal health is a priority, so I can't imagine that not being there, just like I can't imagine health equity not being there in some way. We just have to figure out a way to get all of those things that we care about and that our stakeholders care about into one strategic plan. So that's going to require some creativity and work, but clearly a lot of interest and focus for us on maternal health. The department overall, HHS just released a maternal health action plan. The Surgeon General released a call to action that went along with that. So we're in this space. We're clearly committed to continuing in this space. And so one way or another, it will be reflected in the strategic plan. Absolutely.
Great. And we have another question to highlight that we have seen a large reduction in preventive dental visits for children during COVID-19. And I swear I didn't plant that question, but I will add that my daughter did go to her 6-month dental checkup this morning. So we're staying on top of it. They have you like wait in the car and then you call, like they call you when it's time to come in.
So I think that's a really good point. And we want to think about all of the sort of collateral complications of COVID, right? And what are the impact? So we think about kids being infected with COVID and what are those complications, but we also know that COVID has really disrupted typical patterns of healthcare delivery and the ways that kids and families approach healthcare. And so absolutely, we've seen declines in a number of aspects of preventive care. For the challenge, our challenge is focused on the well visits and immunizations, but I would also say those well visits are an opportunity, you know, part of your exam is an oral exam and you're making sure those kids have a dental home and you're making sure that they're getting connected back for those regularly scheduled dental checkups. So I think this is an opportunity for us to think about linking those primary care medical homes and dental homes as well. And there's nothing that says that groups that care about oral health can't be connected in these kinds of projects and work together. We'd love to see innovative ideas be put forward.
Great. Laura Kavanaugh, I see you have your hand raised. Would you like to unmute yourself?
Sorry, that was a mistake.
Okay, no problem. Just make sure we aren't missing anyone. And then we had another question about whether it is safe to go to the dental appointment, being that talking about oral healthcare.
Yeah. So I think, and I would always, my stock answer is always, let's make sure we remember the guidance from our colleagues at CDC. And think about the ways that practice settings, whether it's primary care or dental, have been adapting to make sure that both patients and staff are safe. Particularly early on, there was a lot of concern, and really quickly, people innovated in this space. And so the example you gave of waiting in the car until your time is called, and then they bring you in and they bring you straight to the room, and you have your visit and they take it out. In some cases, in primary care kinds of things, we've heard about kids going to primary care and they get actually vaccines in the car. The clinic staff will come out and do that, or certain screening which might lend itself there. Some does, some requires being in the exam room. But practices, both primary care and dental, are really adapting very nicely and really trying their hardest to keep, like I said, their patients safe, but also their staff safe. I think you always have to balance that with what's the burden of COVID in your community, what are your own risk factors, but have those conversations. Stay in touch with your primary care providers, your dental providers, ask them what they're doing to help keep themselves and you safe, and if at all possible, continue that primary and preventive care work.
Great, thank you. So I don't see any other questions at this time, so we will move along. And I'm going to turn it over to my colleague, Paige Busnich, to introduce our next speakers.
Hi, everybody. My name is Paige Busnich at AMCHP, and I'm really excited to introduce our next group of speakers who will be talking about some of their wonderful on-the-ground work that they've been doing in New Mexico as through their Title V program. I won't talk any longer because I want to give them ample time to tell you about all of the really neat things that they're doing. So without further ado, I will turn it over to Janice Gonzalez, who is going to introduce the topic. Thank you.
Thank you. Thank you, Paige. We're very happy to be here today to tell everyone some of the things that we've been doing in New Mexico around COVID. I'm Janice Gonzalez. I'm the Title V director, and I have two colleagues here with me who I am really very proud of, and I'm glad that they're going to have the chance to tell you about their work. Okay, next slide. So just real briefly to set the stage, I wanted to explain a little bit about our health department. Our Department of Health is the largest state agency in New Mexico. It has over 4,000 employees and 7 divisions, of which public health is the largest, with over 600 employees, down from around 800 several years ago. So we have been cut quite a bit, but we still are the largest division. And we have a centralized public health system. So we have our central staff in Santa Fe, and then we have regional staff in 4 different regions of the state. Each region has a regional director that then reports up to the public health director in Santa Fe. And then in addition to the 4 regions, we have 3 bureaus, which is where most of the programs and the federal grants are housed. And one of those 3 is the Family Health Bureau. So that's where the 3 of us work. I'm the bureau chief, and we have 6 program areas, including Children's Medical Services. And the 2 people you're going to hear from, Susan Chacon and Susan Merrill, both work for Children's Medical Services. Next slide. So our bureau over the last 9 months, 10 months has been involved in all kinds of ways in the COVID activities. This is just to give you a sense of kind of all the different things that we've been doing. You know, our epidemiology department division, epidemiology division is normally the one that does the case investigations and those kind of things, and surveillance and contact tracing. But with this, of course, they are a small division and they were quickly overwhelmed. So it was kind of all hands on deck. So we've had staff doing case investigations, case monitoring, contact tracing, all kinds of data analysis, data gathering, reports, different reports for different state agencies and the Children's Cabinet, the social work case management, which you're going to hear more about, as well as the pregnancy tracking and follow-up. We've also helped the region staff with direct COVID testing and support for testing. And now we're moving into vaccination, which I just got today. And I know Susan got hers this week, so that's some hopefulness. Okay, and then we've been working with a lot of different state agencies with our COVID activities, and we have relationships with all the birthing hospitals in New Mexico. Next slide. So the COVID work has evolved. It's quite different now than it was in the beginning, March, April, May, when we first started. In the beginning, New Mexico was hit really hard in the Northwest quadrant, which is where the Navajo Nation is. And Susan Chacon worked with Navajo Family Voices to develop a system around food and water delivery for those families. And then both Susans have worked as contact tracers and case monitors and case investigators. So they had all that background kind of leading up to the other work that they have started doing more recently that they're going to tell you about. And, just all kinds of other things, like a resource directory that's been developed, various protocols as things have changed over time, and we've had to change our messaging and make sure that we're giving correct protocols, especially for pregnant women, because the guidance on pregnancy changed quite a bit. And Susan Merrill has been our lead on that. And more recently, the work has been around people in isolation and quarantine, because as our numbers have skyrocketed over the last month or two, they're far higher now than they were in the summer, which was our previous peak. But this is like 4 or 5 times, what it was back in July. So we have a lot more people isolating, a lot more people in quarantine, and some of those people are having trouble getting food because they may not be in an area where food delivery is happening, or they may not have any family members who are healthy enough to go out and get the food for them. So those are the kind of issues that we've been seeing, and that's where Susan Chacon has been stepping in. And before I turn it over to them, I just want to say that I've been so impressed. I feel like these two have gone above and beyond anything that I had expected for them to do. So I'm just really happy that they get a chance to share this with you. Next slide. Okay, I think Susan's going to take over now.
That's me. So thank you, Janice, and it's great to be with everybody. And it has been a really grassroots process. I think the key that this slide represents is that we had really good long-standing partnerships with many organizations across the state, and that really includes our family organizations, our F2Fs, both in the rest of the state and then Navajo Family Voices. We always work closely with MCH care organizations. So just having those relationships in place has really helped our efforts. And in the beginning, both of us, and I know we're like affectionately called the Susans in the emergency response world, but we both worked at different emergency operations centers. So we started meeting folks from different agencies and really getting a better sense of what the overall response was. So that was sort of our beginning. And we just started out kind of texting each other saying, oh, this is going on, this family, and we would try to put together what we could. So next slide, please. So in terms of the social work referrals that we're receiving, there was, of course, we had been seeing increased need, especially around food security, mental health, people needing shelter, you know, a whole range of conditions that the people that are had been hired to do case investigations and contact tracing. It was just beyond their scope of what they could really address. So the system of referrals was set up. And the other simultaneous thing that was going on is the tracking of pregnant women and infants. And Janice and Susan Merrill set up that system. So that was going on, had been going on simultaneously. So we set up our system where I started receiving all the referrals, social service related, and then I triage them and I handle some, and then I would send off to our regional Title V children's medical staff, and who are all licensed social workers in our public health offices. And it's worked out really nicely because they are closer to the local community resources, and we've been pretty successful in connecting folks to what they need. We also have bilingual staff. So all of our Spanish speaking families that we're trying to help, we have staff that can speak to them in their native language. Next slide, please. So I'd say the past 6 weeks with the surge that we've all been experiencing COVID, we saw an increase in need for home delivery of food. People really trying to maintain their isolation and quarantine, which is what we want. So we're trying to do everything we can to get people what they need so they can be in their homes for that 10 to 14 day period. And this really became a collaboration between us, Department of Health, Salesforce, that's the company, many of you probably know who they are. They're doing the contact tracing and the investigations in the state, our Children, Youth, and Family Department, and our main food bank, food distribution, which is the Roadrunner Food Bank. And I had to say it started with one supervisor, a contact tracing supervisor who had been seeing this need, and she and her family just decided, you know, we've got to do something. And then ironically, they live on Corona Road, so they named themselves the Corona Food Brigade, and it was born. So we worked out a partnership with the Roadrunner Food Bank, and when we get a need for a food box, we create a list and we send them the daily list, and it's usually about 3 to 5 families a day. And then Monday through Friday, we have Children, Youth, and Families staff that will go pick up the food. I'm not sure what happened there, and deliver to the family. And for other communities, we partner with churches, St. Vincent de Paul, senior services, sometimes the county and the city. And word's gotten out, and there's a lot of people that want to help us. And we have a new partnership now with the Association of Realtors, where there's over 4,000 members. And that is going to be a little bit of an army for us to try to get food into people's homes. And we work a lot with our social workers in the public health offices, and they'll often pick up food boxes and drop it off at a family's home. So next slide, I think I'm going to turn it over to Susan Merrill.
Susan, you're muted.
Unmute yourself. There you go.
Sorry, I clicked it now. I apologize. So thank you for having us. So I've been early on, I guess I want to say end of March, beginning of April. We were seeing, pregnant women positive for COVID. So between Janice and I, we met with our epidemiologists and spoke with people at the CDC to put our protocol together. So my role is I get notified of all pregnant women who are positive for COVID, and I reach out and I call and I talk with them and educate them. What's really important and what I hear every day is the fear of what's going to happen at time of delivery, the concerns about the possible effects on the baby, The other big important piece of education that I've been providing that we put into place is around breastfeeding. And those are critical, and those come to me through the hotline as well, through the COVID hotline that we have here at the state. And what happens is we've had situations where, apologize, I have a pet. We have situations where breastfeeding moms, because they were so worried, would stop breastfeeding if I didn't contact them or they weren't contacted within 24 hours. And then the isolation due to COVID, especially with pregnancy, I've seen a huge increase in anxiety and depression, along with an increase in substance misuse and domestic violence. And by being able to reach out and identifying, and because of the contacts and connections that we've created, we can get people help fairly quickly. Next slide. So here's what the impacts are looking like. People are really having to travel distances to get medical care. We have situations where a local small hospital may turn people away because they're not sick enough. We have people that need lodging or placement. Recently had a mom who delivered, baby was in the NICU, and she still needed isolation. And she didn't live, because Albuquerque is our biggest city and that's where our largest hospitals are. She didn't live near Albuquerque. She was at least 3 or 4 hours away. So through our lodging system, the social worker at the NICU called me, and we were able to set her up and her husband with lodging so they could be in Albuquerque, even though they were in isolation and in daily contact with the hospital. Next slide. So I just want to give you a couple of case examples. When we talked about the Northwest Quadrant, the Navajo Nation, one of my first cases early on was a woman who lived in the middle of nowhere. And she had called the COVID hotline and she was very sick. And the nurse said, well, you need to call EMS. She said, I don't have EMS where I live. Ironically, I'd gotten a notification on her, so I had contacted her as well. And we together made a plan, because I could tell from the conversation she was really, really struggling with her breathing. And by day 3, she was hospitalized. What ended up happening was her sister went, picked her up, got her in the car, took her to the nearest hospital, and then she was transferred to a larger hospital. She was hospitalized for, I want to say, close to 3 weeks. She's been since discharged and has delivered safely, but it was a very critical time, and she wanted contact with me daily, which was fine, and I was able to do that. This is what we see a lot. People that live 2 to 3 hours from the delivery hospital, recently cleared from COVID, and she could resume care, but the provider had misinformation. As Janice mentioned, the information has changed so quickly. We have had providers requiring 2 negative tests. And in pregnancy, we know that can take a while to get, depending how far along they are. And so that really was delaying our process. We have now changed that with all the new guidelines that we've rolled out, and with the help of the New Mexico Perinatal Collaborative as well. So I every day email that information to pregnant women so they can resume care. I also send them a letter from the department that officially clears them out of isolation. Next slide. This was a really challenging situation. So this woman had delivered and her baby was 4 weeks old and she was very, very sick. And so I called her and she was really struggling, and she was working with her primary care doctor and waiting on medications, but she had decided to isolate herself and stop breastfeeding, and actually had a friend who assisted her with breastfeeding the baby. What ended up happening is we did end up hospitalizing her. And she, when after she was discharged from the hospital, she and I were in communication. She was still requiring isolation. She wasn't done, completed with that infectious time frame. But what worked was that she was able to restart her breastfeeding after 20 days of separation. Next slide. And then These are yours, Susan.
So these are mine, thanks. So these are just some, other than food issues, some examples of situations we've come across. So the infected woman that we talked to was a primary caregiver for her 92-year-old mother, who lived in a house next door to her, and her mother was negative. So we contacted her, and really it was just trying to help her kind of process and think through how to set up some arrangements to take care of her mother. So we got the PCP to order home health care, and then we worked with the primary caregiver to talk to some friends and neighbors who assisted with food and check-ins. And then we had I always say this is one that really stood out for me because it was very intense. The father, 2 teenage girls, and one of them was schizophrenic and had a tendency towards violence toward the younger sister, so she couldn't be left unsupervised. And the father was very sick and he really needed to go to the hospital. So we spent quite a bit of time. We found out, we didn't know what to do at first. Then we found out that the girl's mother actually lived in Mexico. So we had to coordinate transportation for the 2 minors across the international border. And then the father was able to go get the health care that he needed. And I think I have one more example. Next slide, please. So they're in New Mexico, we have a lot of, one back page, we have a lot of multi-generational families living together. And then this is just one example on the Navajo reservation. As you've heard, there's many families on the Navajo reservation that don't have running water. So we worked with our Janae Relief, which is part of Navajo Family Voices. They really put together an amazing relief effort, and we were able to get food to them and delivery of water so they could wash their hands and do what they needed to do. And they also started delivering solar powered laptops so the children could link to their classrooms for remote learning. So it's just another example of working together. So our last slide, lessons learned. As I think we've all been talking about, our partnerships are critical in this pandemic. Not one program or agency can do it alone. We're all working together. The flexibility of the Title V funding has really given us the ability to be creative in our response. And for that, we are truly grateful. Our social workers, our Title V social workers around the state have been phenomenal in responding to their needs. Since we work in the healthcare field, we understand how the healthcare system works. And I think that's been an invaluable skill set to bring to this pandemic response. So just kudos for all of us social workers out there. Really, the skills have been really phenomenal in responding to all the issues that we have to respond to. And I believe that is it for us. Thank you so much.
Thank you, Susan, and Janice. That was really wonderful and great to hear about all of the examples of what you all are doing and the partnerships that you're only continuing to strengthen. So thank you. Before I pause for questions, I did want to put a plug in to others who are on the call. This is kind of our first time having folks from State Title V program talk about their work on the town hall, and we'd like to continue that. So if there's something you'd like to share about the work that any individual or director is doing in your Title V program, we would love to feature you all on a future town hall. So if that's the case, you can send me an email. I'll pop that in the chat box in just a moment. But we would definitely love to chat and see how we can elevate and really lift up all of the the great examples that you all are doing. So thank you all so much. I see there's a hand raised from Noel.
Hi, thank you both Susans for sharing that. Those amazing examples of how you're helping your community. I do have a question for you. So with your other CSHCN Title V goals, are you still working on that, or have you put those on hold? Like, how have you balanced all the workloads and different, activities, how you serve like your public, like, I mean, you have a lot of different things you're doing. So I'm just kind of curious, like how you're balancing that with your teams.
That's a really good question. And we do continue to, this is sort of our, our day job continues, and we're very dedicated to serving our families and our CSHCN population. This is just added duties, and I guess one benefit of working at home a lot is you don't have commute. You can work till 9 o'clock at night. You can work weekends, so it's just a lot of extra hours. I don't know if you want to say anything, Janice and Susan.
The only other thing I would say is one of the interesting things, it's also helped us to identify children and youth with special health care needs. So when I reach out to pregnant women or families with babies under a year old, I also, I do a full assessment typically with that family. And so I've made referrals to our CMS local offices for services, because we're finding families that didn't know about our program either. So it seems to all work together.
So are they finding you with your hotline? Is that how you're initially engaging with, let's just say, additional families besides the normal ones you work with?
Right.
Hotline?
It's sometimes through the hotline. Those are like the emergency, we have somebody's pregnant, they have questions or breastfeeding. But then the regular ones are through our Salesforce folks that have gotten to know Susan and I really well. And so they literally notify us on every baby, and Janice is on most of those too. And so then we reach out and we call the family and we learn more about what they need and what's going on. So I think like we've identified a lot of children with asthma. We've had situations where families couldn't get their asthma medication, and our CMS social workers have been, the local ones have just stepped right up and helped them to do that.
Great, thank you.
Thank you. And I'm so sorry, because I feel like we could spend the rest of the call talking about the amazing work that you all are doing. And hopefully, we're able to serve as a connection point and can share your contact information for other listeners and states that want to adopt similar processes. But thank you. Now I will turn it over to Dr. Rifos from CDC to share with us some updates.
Thank you very much, Amy. So like Amy said, my name is Jinita Refaus. I am the Acting Division Director for the Division for Birth Defects and Infant Disorders at CDC in the National Center on Birth Defects and Developmental Disabilities. I am taking this place for Dr. Karen Remley, who is working on vaccines in the COVID response. So yeah, I'm glad to give you some of the updates that we have. It's been a busy time, as you might have guessed. One thing that I do want to tell you is that not everybody may be able to get the vaccine, the COVID vaccine just yet, but all of us can get our flu vaccine. So you can start by getting that one if you haven't done that already. And then for the COVID response, just some updates. On Friday, December 11th, as you know, the EUA was issued by the FDA for the Pfizer vaccine. The Advisory Committee on Immunization Practices then met on Sunday to review and vote on those recommendations that were submitted to the CDC director and have approved them. Another vaccine is currently awaiting emergency use authorization from the Food and Drug Administration, and then that would come to ACIP next. CDC and Operation Warp Speed, they're partnering and Warp Speed partners are working closely with state and local health departments on preparing detailed but flexible plans specific to each jurisdiction, including consideration of critical infrastructure and healthcare workers, high-risk individuals, health equity issues, and lessons learned from the 2009 H1N1 pandemic. I think it's important to note that each plan is state and jurisdiction specific. The plans will be executed in phases by the federal government, the 64 CDC jurisdictions, which includes all 50 states and 5 large cities, and then also territories, industry partners, and other entities. The end goal and the ultimate goal is for every person in the US to get a COVID-19 vaccine. In the beginning, we do expect there to be a limited number of doses available. Even into the new year, we think that there's going to still be limitations in the number of doses that we have available. And so in that setting of constrained supply, we really need to target administration to achieve high coverage in those priority populations. But hopefully in the spring, we expect a large increase of doses to become available, especially if additional vaccines become approved by the FDA. And if and when FDA authorizes use of those vaccines, there will be a large jump in supply. And then hopefully we will have sufficient vaccines to meet demand, and supply will increase and therefore allowing more access. So CDC and Operation Warp Speed are working to get those first vaccine doses out once the vaccine is authorized and recommended. And so they're really wanting to get those vaccines into arms rather than waiting until there's enough vaccine for everyone. But it is really important that the initial supplies are given to people in a fair, ethical, and very much transparent way. So ACIP has set the following goals for recommending which groups should receive COVID-19 vaccines if the supply is limited. The goals are to decrease death and serious disease as much as possible, preserve the functioning of society, reduce the extra burden the disease is having on people who are already facing disparities, and increase the chance for everyone to enjoy health and well-being. And then a little bit more specific to MCH, so COVID-19 vaccine and pregnant people. There are currently no data available on the safety of COVID-19 vaccines, including the Pfizer BioNTech COVID-19 vaccine in pregnant people. But based on current knowledge, experts do believe that mRNA vaccines are unlikely to pose a risk for people who are pregnant. And if pregnant women are part of a group that is recommended to receive a COVID-19 vaccine, such as healthcare personnel, they may choose to be vaccinated. Pregnant women who experience fever following vaccination may be counseled to take acetaminophen, since fever has been associated with adverse pregnancy outcomes. And I'm hoping that Sasha can show us the links for more information on the CDC website. We have a website specifically for providers around the clinical considerations for the vaccines, and then there's also one specific for pregnant women. And then I also want to remind you that the data on COVID-19 during pregnancy and the severity of maternal illness, so that level of information, is updated weekly and has moved to CDC's COVID data tracker website. So you can find that also on CDC's website. And the data on COVID-19 during pregnancy for birth and infant outcomes will be updated today. And I also wanted to let you know that CDC is expanding its monitoring of vaccine safety and evaluating the COVID-19 vaccine safety in real time. So vSafe is a new smartphone-based after vaccination health checker for people who received COVID-19 vaccines. This system uses text messaging and web surveys from CDC to check in with those that have received a vaccine following received a vaccine for COVID-19. It'll also provide second vaccine dose reminders if needed, and telephone follow-up for anyone who reports medically significant adverse events. So it is definitely something that, for those of you that I heard had a vaccine, something to consider. There are 2 important upcoming calls from CDC that you could consider attending. One is the COCA call this Friday, so tomorrow, during which there will be a discussion of what clinicians need to know about the Pfizer, BioNTech, and Moderna COVID-19 vaccines. So that's tomorrow from 2 to 3. And we will, I see Sasha already put the link in the chat box. And then on Monday, there is the update, COVID-19 partner update on COVID-19 response vaccines. So Dr. Sarah Mbeye, who's a medical officer with the National Center for Immunization and Respiratory Diseases, will be joining the call, and she is leading the CDC COVID-19 Vaccine Task Force Clinical Guidelines team. So as you might imagine, there's a lot of clinical guidelines that go around and go with the vaccines. And then specific to breastfeeding and lactating women, there unfortunately also, as of right now, is no data on the safety of COVID-19 vaccines in lactating women or the effects of mRNA vaccines on the breastfed infant or milk production. Again, mRNA vaccines are not considered live virus vaccines and are not thought to be of risk for a breastfeeding infant. If a lactating woman is a part of a group, such as healthcare personnel who's recommended to receive a vaccine right now, she may choose to be vaccinated. So that's my update around vaccines. And then I want to go to the next section that we provide guidance for, which is schools. There are a number of new tools. And I've given you updates on those before. And these tools really have been driven by feedback that we have received from states and localities as part of technical assistance. So, when a state reaches out and CDC goes to assist them, we learn a lot, and we're using that feedback to improve the tools that we have. And part of that is also based on requests from educators. As you know, the teachers and schools have a lot of questions, and so we're trying to incorporate those questions into our tools. So we just released 2 new tools that will help school and district administrators safely resume in-person learning, whether for the first time this school year or after the winter holiday. So the K-12 School COVID-19 Mitigation Toolkit, it really breaks down all of CDC's guidance into actionable checklists. So it really helps you go through step by step to consider different COVID-19 mitigation strategies to implement in their specific schools. And after reviewing the K-12 schools COVID-19 mitigation toolkit, the Getting Schools Ready can be used to plan and execute a school walkthrough with local health officials. So once the school thinks they're ready, you can have a guide on how to then have that walkthrough. So these tools are really based on our existing resources and recommendations, and they're meant to be actionable and user-friendly, so we hope you find them as such. And then lastly, I want to highlight a couple of MMWRs that have come out since I last spoke to you 2 weeks ago. The first one is on factors associated with positive SARS-CoV-2 test results in outpatient health facilities and emergency departments among children and adolescents aged under 18 years. So this is data from Mississippi that is specific to children. Then next, obviously, the Advisory Committee on Immunization Practices interim recommendation for use of the Pfizer-BioNTech COVID-19 vaccine. So that's the important MMWR on ACIP's recommendation. Then the estimated resource costs for implementation of CDC's recommended COVID-19 mitigation strategies in pre-kindergarten through grade 12 public schools. So I think that will also be really helpful to get a sense of what the costs might be. Then there's one on trends in U.S. emergency department visits related to suspected or confirmed child abuse and neglect among children and adolescents aged under 18 before and during the COVID-19 pandemic. And that's some really, to me, heartbreaking news, but important to be aware of. So please check that out as well. And then racial and ethnic differences in parental attitudes and concerns about school reopening during the COVID-19 pandemic. So I think that could also be really informative as you're planning with your school systems on how to reopen. I think it's important to be aware of those racial and ethnic differences. And then the last one I wanted to mention is implementing mitigation strategies in early care and education settings for prevention of SARS-CoV-2 transmission in 8 states. So that's really for the early care settings. So, and that's where I wanted to leave it. I threw a lot of information at you, and I know that Sasha has kept up with putting all the links in, so I hope you will find those very helpful. And I want to thank you for your time and for your hospitality on this call, and I wish everybody very happy holidays.
Well, thank you for all the information and for sending the links to the various calls that are coming up, as well as the MMWRs. And I see we are running towards the end of our session here. So what we're going to do is we're going to hold off on the ACA presentation until our call in January. So you will just have to wait a little bit longer on that. And I will remind you all that the call for proposals for AMCHP's next conference it was extended until December 30th. So if you were not able to get in your proposal yet, you still have another 2 weeks. So we hope to have more interested participants who can participate. Again, you know, it's uncertain right now about what an in-person gathering may or may not look like, but there will be virtual regardless of whether it's hybrid or just go completely virtual gathering this year. So please, we are interested and really excited about our theme, Global Meets Local. Our next call will be January 7th, and I just want to make a note that we're going to be changing the frequency a little bit. In January, we will have 2 calls on January 7th and January 21st. Starting in February, we will go to the first Thursday of each month. Many of you will be getting some more information about timing and scheduling for the Title V partnership meeting that will also be virtual this year. And so we don't want to put too much of a demand on your schedule. So you can register for the 2 January town halls. The link that is both in the slides and in the chat box right now from Jess Cohen. So we hope you will join us for those, but then, you know, depending on what kind of calendar holds you have, we will move to the first Thursday of the month for February, March, and April, and then we'll reassess about timing and frequency from there. And then finally, just want to wish you all a happy holidays from the AMCHP staff. We had a little virtual lunch gathering yesterday, which was quite festive. And, you know, we know these holidays are different than normal, but whatever you are doing to stay connected with your loved ones, we hope you stay safe and healthy and get a little time to practice the self-care that we've been talking about and none of us probably do enough of. So happy holidays to everyone. Thank you for joining us again, and we will see you all in January.